So, dear trainees, welcome and thank you for being here today. I'm Navneet Singh, your host for this webinar. I know that today's topic might bring up a number of questions from you. So, you may type your questions in chat box, and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request our NBMS National Webinar Coordinator, Professor Dr. Narendra Pal Singh, to start this session. Welcome, sir. Over to you.
Thank you, Navneet, and again, welcome, dear trainees, on this regular show of ours on Tuesday afternoon on topics in internal medicine. And I have a great privilege and honor to continue to invite my very close friend, Professor Jyotirmoy Paul, whom you heard earlier on history taking in CNS. And he is a well-known figure in not only in national scene, but internationally also he's working quite hard to bring together SARC physicians, and he has a passion of teaching. So that is how I requested him, and he has agreed to my request to talk on a very, very important, pertinent topic on examination of the cerebellum and its disorder, and which is unfortunately neglected in our internal medicine training program. And I'm very sure after the end of 40-45 minutes, you will be quite learned as far as cerebellum is concerned. And then if you have any questions or queries, both of us will be very happy to answer them. So welcome, Professor Jyotirmoy Paul, and kindly take over from here.
Thank you, sir, for your kind introduction. And I'm really very happy to take classes of the DNB student across India. So, without wasting time, I am going to the issue of cerebellum, how to examine what is the role of cerebellum and what are the disorders. Cerebellum basically not involved in production of the muscle power. For the muscle power, it is the motor cortex, corticospinal tract. But function of cerebellum is basically for the smooth coordination, accuracy, and execution of the voluntary movement. So basically, corticospinal tract provides the crude movement, not the accurate movement. If you want to grasp one mobile or if you want to dial a number, the corticospinal tract can give the gross movement, but the accuracy, whether your finger is touching the, suppose 98300, this accuracy made by the cerebellum, that is the role. Also recently it has been observed that in the cognitive and affective function, cerebellum also has some role. So to come very briefly on the anatomy, this is a very basic, because so many symptoms and sign we will discuss, and which part is responsible for development of the which symptom, that depends on the anatomy. So very, very brief, you should have some idea on the anatomy. Location, it is the posterior to the brainstem and fourth ventricle and below the tentorium cerebelli. So cerebellum is basically has the two lobe, two hemisphere, and connected by on midline zone, that is called vermis. So this is two hemisphere connected by the vermis midline zone. So again anatomically, phylogenetically, it has the three part. One is the anterior lobe, that is called, if you come from the primitive to newer development, first is the flocculonodular lobe, that is the very primitive lobe of the cerebellum, called archaeocerebellum. Then is coming the posterior lobe, that is called paleocerebellum. Then is coming to the anterior lobe, that is the neocerebellum. So phylogenetically, it is divided into three parts. You see, this is the flocculonodular lobe, most primitive part. This is responsible for the equilibrium. This is vermis, and this is the paravermis area. This vermis is responsible for the gait and stance and movement of the trunk muscle, and particularly the trunk and axial muscle and proximal limb muscle, and that is the hemisphere. That is hemisphere. So this hemisphere is responsible for the limb movement, particularly the distal limb movement. So this is for the equilibrium, this is for the trunk muscle and proximal limb muscle, and this is for the distal muscle. This is the vermis area, this is the paravermis area. This basic knowledge is very important to understand the different disorders of the cerebellum. So two horizontal fissures, this is divided into three parts. One is anterior lobe, this is the posterior lobe, and this is the flocculonodular lobe. Okay, this is the gross anatomy of the cerebellum. So if we come to the, if you relate to the anatomy with the function, I told one is the vestibulocerebellum. This is called flocculonodular lobe. Another name is the vestibulocerebellum because this is connected with the vestibular nuclei. Vestibular nuclei is sometimes called by evolution maybe a continuation of the cerebellum. So this is the primitive lobe connected, so it is responsible for the equilibrium, particularly the eye equilibrium, balance and eye equilibrium for the this flocculonodular lobe. And this vermis and paravermis is called the spinocerebellum. This is responsible for the motor execution. Suppose your trunk muscle and the proximal limb muscle, your hip girdle muscle, basically responsible for the motor execution. You can walk. So these muscles are controlled by or modified. Basic control by corticospinal tract, but this area spinocerebellum, it modify the signal that are coming through the corticospinal tract to become the movement more accurate, precise, and goal oriented. Now this is the lateral hemisphere. This is called cerebral hemisphere. So this is cerebral hemisphere for the motor planning. Because this cerebral hemisphere, there is a newer evolution is newer. Basically, they receive input from the by spinocerebellar tract and cuneo-cerebellar tract from the limb muscle, from the body, and accordingly they send signal to the motor cortex. And because motor cortex is responsible for the motor execution, so what is needed by your limb, that message is sent by the cerebrocerebellum to the motor cortex, so that motor cortex can plan accordingly. So impression or demand is carried by the spinocerebellar tract given to cerebrocerebellum. This is the cerebrocerebellum. From cerebrocerebellum passes to the motor cortex, and now motor cortex can accordingly plan the motor execution as per need of the limb. This is the very important works done by the cerebellum. Three part of the cerebellum. Now going slightly more details of the vestibulocerebellum, they get input from the vestibular nucleus and superior colliculus. That means visual and vestibular input, and output is again to vestibular nuclei. And its function is basically the pursuit movement of the eyes and control the axial musculature. So disorder of the vestibulocerebellum, there is a defect in the pursuit movement, slowing of the pursuit movement, and abnormality of the vestibulo-ocular reflex. So these two defect in the pursuit movement. So if there is a defect of the pursuit movement, what abnormality we will observe? There is a nystagmus. And abnormality of the vestibulo-ocular reflex we will see in any disorder of the flocculonodular lobe. Now we are coming to the spinocerebellum. I told it is the vermis and paravermis area. They get input from the spinocerebellar and cuneo-cerebellar tract and also trigeminal nerve, at which carries the sensation from the head and neck. So output is one from the spinovermis to one to vestibulospinal and reticulospinal activity tract in the brainstem. These two fibers, vestibulospinal and reticulospinal fibers, they basically control the proximal musculature and axial muscle. So this is one function. Second function is from the vermis, some of the fiber reach to the rubrospinal tract, then to the thalamus, then to the corticospinal tract via premotor cortex. So in this way, the vermis also control the distal musculature of the limb to some extent, but basic duty is the axial and proximal muscle activity of the trunk, so responsible for the gait and stance. So in vermis lesion, we will get basically the gait abnormality. Now, spinocerebellar tract causes the one question: why in cerebellar disease we get a ipsilateral lesion, but in cerebral cortex disease we get a contralateral lesion? Because when the spinocerebellar pathway, because the output from the spinocerebellar, that is the vermis, first causes the midline to reach the opposite red nucleus. So first is causes. Then it go to the thalamus, then from thalamus go to the cerebral cortex. And from cerebral cortex, output comes via corticospinal tract and again cross the midline. So there is a two-time midline cross. As a result, If there is right-sided cerebral lesion, we will get symptom at the right side, that is ipsilateral. So that is why in cerebral lesion we will get the ipsilateral finding, and in cerebral cortex lesion we will get the contralateral findings. Cerebrocerebellum I already described. This is they get the input from cortex, then pons, then cerebellum. That is called cortico-pontocerebellar pathway that passes through the middle cerebral peduncle, and this gives the required information about the motor planning by the motor cortex, and output through the dentate nucleus. It goes through the superior cerebral peduncle. So cerebral information come through the middle cerebral peduncle, output go through the superior cerebral peduncle to opposite red nucleus, then thalamus, then to the primary motor cortex. So any disorder of the cerebrocerebellum, that means cerebral hemisphere, that will result in motor planning and execution. That means there will be delay in the initiation, delay in the termination, deficit in the motor planning, and chaotic and irregular timing and preciseness. That we see in disorder of the lobe of the cerebral, that is the cerebellum. And this is the very basics of the different symptoms or signs that we get in the cerebellar lesion. So when I discuss about the three peduncle: superior peduncle, middle peduncle, and inferior peduncle. These three peduncle attach cerebellum with the brainstem. What is the function of the peduncle? Superior cerebral peduncle basically is the efferent fiber. It is basically for the efferent fiber. Efferent fiber means output fiber. There is a dentorubrothalamus. By the superior cerebral peduncle, fibers from dentate nucleus go to the red nucleus, thalamus, and cortex, and also directly to the tectal fibers. So this is basically output fiber. Middle cerebral peduncle basically input tract. That means from the cortex come to the pons, from pons enter to the cerebellum, as if motor gives a information to the cerebellum what he has planned. So he asks cerebellum whether my planning is okay or not. If the cerebellum say yes, your plan is okay, then the corticospinal tract act and do the required movement. Inferior cerebral peduncle basically the mix. There is both afferent and efferent fiber. Afferent fibers are basically posterior spinocerebellar, cuneo-cerebellar, reticulocerebellar, trigeminocerebellar, olivocerebellar, vestibulocerebellar. To some extent, I described before. Basically, the afferent and efferent also cerebro-reticular and cerebrovestibular. This efferent basically comes from the vermis. So, efferent basically control the axial and proximal muscle movement, because vestibulospinal and reticulospinal is responsible for the proximal limb muscle movement, and rubrospinal fiber responsible for the distal muscle movement. When you see the cross section of the anatomy of the spinal cord, this information is very important to understand the case of paraplegia or quadriplegia. So organization of the cerebellum, I am not going into the detail. There is a three nucleus and three layer. This is a complex, not much related to with the clinical part. So I am skipping this aspect. So now we are coming to the clinical manifestation. Depends on the function, because I told there is a three part. One is the flocculonodular lobe, one is the vermis, one is the hemisphere. Flocculonodular lobe basically for the eye movement and the balance of the eye. Vermis is basically gait and stance, that is the proximal limb muscle and axial muscle, and hemisphere for the distal muscle. So depending, and the output of the cerebellum is basically excitatory. So depending on this basic knowledge, basic disorder or cardinal features of cerebral dysfunction is the ataxia. Ataxia means there is a lack of coordination of the activity. So ataxia several component. One, there will be dyssynergia. That means when we work, there is a synergia between the agonist and antagonist muscle. How much my biceps will flex and how much the triceps will prevent. That is called synergia. That is controlled by the cerebellum. So this synergia is lost. Dysmetria. I want to touch in mobile number 9. I will accurately touch the number 9, not the 8 or 7. This accuracy is maintained by the cerebellum. Disorder is called the dysmetria and agonist-antagonist coordination. So I want to pick up a glass, but I cannot. I can proceed my arm or hand appropriately up to the glass, not beyond that. This is basically controlled by the reciprocal innervation of the agonist and antagonist. Again, this is controlled by the cerebellum. So cerebellar disorder causes the ataxia, tremor, and hypotonia, because I told cerebellar output is basically excitatory, dysarthria, nystagmus, disorder of the flocculonodular slope, and cognitive function. I mentioned before, this is a newer aspect. The cerebellum also responsible for the cognition. Ataxia, it can involve the gait, it can involve the trunk, it can involve the limbs. And gait after ataxia, it can be early stage, it can be late stage. Difficulty in walking, early stage, there will be difficulty in walking in narrow passage, difficulty in climbing stairs or declining. But tandem gait, I will show the picture after all. Tandem gait can elicit the early involvement. So this is the feature of the gait ataxia early stage. But when it will be late stage, then as if you are walking like a drunken, you have taken a lot of alcohol and walking like a drunken. So you walk on a broad base, there will be tendency to fall in forward or backward, and there is an inability to stop while needed. This is the features of gait ataxia at the late stage. Limb ataxia, there is a clumsiness while doing activity. I asked you pick up the glass, pick up the mobile, you cannot, your hand is going here and there, cannot appropriately pick up the mobile, and involvement will be ipsilateral, not bilateral. But truncal ataxia, there will be difficult to sit upright without back support due to oscillatory movement of the head and neck. This is the truncal ataxia. This we will see in case of Hermes lesion, and limb ataxia we will see in case of cerebral hemisphere lesion. Again, we are coming the ataxia component. One is the dyssynergia, because normally the harmonious and coordinated action of different group of muscle is governed by the cerebellum. In case of dyssynergia, act is broken down into the small component part and carried out in jerky and erratic way. I will show the picture later on. Dysmetria, error in judging the distance, speed, power, and direction. Suppose I told you touch your nose. Normal person can touch the nose appropriately. But if I cannot, my finger stops before nose or cross the nose, that is called hypometria or hypometria. That is common in cerebellar disorder. That means I cannot judge the appropriate point that I am asked to do. Then agonist-antagonist coordination. When the ability to stop the agonist muscle and to contract rapidly the antagonist muscle. This is governed by the cerebellum. I told you click the mouse, because at a certain time my agonist will stop, and after clicking the antagonist will act and my hand will come out. So this is the coordination. Rapidly when the agonist stop, immediately antagonist start acting. So abnormality is called the dysdiadochokinesia. That means I told you do like this rapidly, you see like this. Agonist, antagonist. I can do it because I have no cerebral disorder. But if you cannot do properly, that means there is a defect in the agonist-antagonist coordination. That defect is called dysdiadochokinesia. The clinical method basically described or made on this defect. Tremor, very important. Cerebral tremor never present at rest. It is evident only in action. That is why it is called the intention tremor. In upper limb, tremor present when approaching to the target. In rest, can you see my hand? There is no tremor. But when I am approaching to the nose, there is a perpendicular to my axis, there is a tremor. It is like this. I told you, touch your nose. Perpendicular to the axis, there is a tremor. And tremor will be more when I am almost approaching to the target. From here, tremor will be less. It will go on increasing in a perpendicular plane. Coming to the nose, it is go on increasing. So this is called the cerebellar tremor. And proximal muscle is more involved than the distal, but in essential tremor, it is the distal muscle which is more involved. Postural tremor with outstretch. I outstretch my hand. Can you see my hand? There is a tremor is found. Titubation. When the cerebellar tremor involves the whole body and head. There is a swinging of the whole body. That is called titubation. This is a different type of tremor. What we see? Why tremor is found? There is a pathway from dentate nucleus, where the deeper cerebral nuclei, to red nucleus. And this pathway, if the dentorubral pathway is affected, that pathway passes through the superior cerebellar peduncle. We see the tremor. So tremor present means there is a defect in the dentate nucleus, or lesion in the superior cerebellar peduncle, or lesion in the red nucleus. If there is such lesion, we see the tremor. But in a lesion in the vermis or in flocculonodular lobe, we will not get the tremor. Hypotonia in acute lesion cause the hypotonia, not the chronic lesion, because cerebellar in output is basically excitatory. Speech again, there is a lack of coordination between the muscles of the articulation and phonation. When I talk that means my phonation, vocal cord act, but sound when is coming, my pharynx is open, my lip is working, my tongue is working. So there is needed articulation or coordination between different muscles of articulation and phonation. If this coordination is lost, speech will be slow, slurring, ataxic, variable volume, irregular interval between the syllable, and maybe explosive. That is called the scanning speech found in the cerebellar disease. Bulbar syndrome, again there will be dysphagia and choking due to lack of coordination between the muscle of the swallowing. Oculomotor abnormality, very important in the nystagmus. This is one of the very important sign in the nystagmus. What we see in there is a gaze epoch. If I say you see in the right side suddenly, so gaze epoch. When I ask to see in a particular side from the primary position, I ask the patient to look to the right side or left side. We will observe the gaze, and first component will be towards the affected side. Rebound nystagmus means first there will be first component to the affected side, but after that there will be reversal. The first component will be to the opposite side. That is called the rebound nystagmus. Particularly change direction while asking to saccade back to the primary position. Periodic alternative nystagmus, another very important nystagmus. First there will be nystagmus first component to the right side, then the eye will come back by the pursuit movement to the primary position. Again now there will be first component to the left side. That is called periodic alternative nystagmus. Downbeat nystagmus is basically found in the lesion of the vestibulocerebellum, and upbeat nystagmus we see lesion in the vermis lesion. Downbeat, upbeat means first component towards the below, that is called downbeat nystagmus. In flocculonodular lobe lesion we see upbeat nystagmus means first component to the above. So this is the gaze epoch nystagmus, rebound nystagmus, periodic alternative nystagmus, downbeat nystagmus, upbeat nystagmus. One common mistake I can tell the students, sometimes it is answered that downbeat nystagmus means looking down, you are getting nystagmus looking downward. No, that is the gaze epoch nystagmus. Downbeat nystagmus means eye at the primary position, but there is a nystagmus and first component downward. That is called downbeat nystagmus. Saccades and pursuits. Basically, saccades and pursuit, not going into the details. Basically, this is governed by the flocculonodular lobe. In case of saccades, the velocity of saccade is normal, but there may be hypo or hypermetria. When suddenly you see, I ask like this. You suddenly see my finger, so there will be saccade to follow the object suddenly. And after that, my eye will again come back to the primary position. That is called pursuit. And saccade means suddenly I try to look to the right side, my finger. That is called saccades. So velocity of the saccade will be normal, but there will be hypo or hypermetric saccade. That means my eye cannot reach to the target properly. And pursuit will be slower, may need the catch-up saccade. So then the ocular skew movement, ocular motility disorder, opsoclonal flutter, visual symptom, vestibulo-ocular reflex may be lost in case of flocculonodular lobe lesions. So these are the lot of eye abnormality we can see, and particularly the macrowave square jack. It is more than 10 degree, very characteristics of the cerebellar lesion. So gaze epoch nystagmus, periodic alternative nystagmus, rebound nystagmus, macro square wave jerk. These are characteristics of the cerebral lesion. Non-motor function, I told something not going is the personality disorder, mild language disorder, some changes in the disturb in the planning, set shifting. This non-motor symptom can also be found in case of cerebral lesion, because I told one some of the fibers through cerebellar peduncle go to the red nucleus, then thalamus, then to the motor cortex. When it is going to the primary motor cortex, some of the fiber reach to the frontal cortex and prefrontal cortex. So there is the area of the different executive function. So they also modify the frontal and prefrontal cortical function. So in this way, cerebellar dysfunction can have effect on the function of the prefrontal cortex. That is why we see the personality changes in case of cerebral lesion. So with this background knowledge, we should know how we examine the patient. This is the theoretical knowledge. What are the examination tools? One is the deviation of the limb. These are the tests. So now I am going one by one. One is the deviation of the limb. Disturbance of the maintaining the normal alignment of the limb, particularly while working with eye closed. Because when I walk, what happens? The both arms are adducted and there is a swinging from the elbow. So this is a normal alignment. In case of parietal lobe lesion, there will be drift upward. In case of pyramidal tract lesion, there will be pronation. So pronator dip. But in cerebral lesion, there will be drift laterally upward, downward towards the side of the lesion. So our hand will be like this, not like this. So deviation of the limb. Rhomboid style, I will come later on. There is a displacement of the limb after brisk tapping. If there is a hypotonia, if you suppose my arm is like this, you give a tapping, what will happen? This will displace very easily. But in case of corticospinal tract, there is a spasticity, there will be little displacement. But in cerebral hypotonia, what will be? You will go tapping, arm will be like this, then it will come back to the original position. So this is called cerebellar hypotonia. There is a muscular hypotonia, very easily displacement. In pyramidal tract lesion, little displacement. In cerebral lesion, if you tap like this, it will fall again after several like this, it will come back to the original position. So displacement of the limb after brisk tapping. Now the rebound phenomena. This test is very important. I am coming to the test. What is the rebound phenomena? Arm should be abducted at the shoulder, like this. You see, arm is abducted at the shoulder and elbow is flexed and forearm is pronated. Now you put your hand like this. So you try to pull your forearm and patient will try to pull his forearm. So examiner will pull this side, patient will pull this side and keep your one hand like this. So what will happen? Suddenly you release your arm. What will happen in normal person? It is like this. In normal person, your arm will not move further. But in case of cerebellum, arm will suddenly will fly to your face, because there is the checking system. What will happen when you are pulling this side? Biceps and brachioradialis are pulling your forearm to this side, to patient size, and this is checked by the triceps. So there is a very good coordination. What will happen in cerebral disorder? When you have released your arm, this check by the triceps will not be followed after the contraction of the biceps and brachioradialis. So there will be unchecked contraction of the brachioradialis and biceps. So arm will suddenly will try to hit your face. To prevent the injury to the face, the examiner has keep his hand like this, so that arm will hit the examiner's hand. This is called the rebound phenomena. This is very important. This can detect if there is a cerebral lesion, there will be unilateral or ipsilateral derangement or rebound we can observe. Next is dysdiadochokinesia. I told this is like this. Dysdiadocho, rapid alternative movement. Because if there is a proper coordination between the agonist and antagonist, I am doing like. So there we can do smoothly. But if there is a discoordination due to cerebral disorder, I cannot do it properly. So foot tapping, you put 1 feet here and you repeatedly your press your foot. This is the minimum cerebral disorder can be picked up by this method. Next slide. Next is finger nose test. I am coming like this. You ask the patient, you close the eyes, you ask the patient to touch his nose. Finger, first outstretched hand, then touch your nose. In case of, this is called test of the dysmetria. I told cerebellum assess the accuracy or judge the distance. If there is a dysmetria, either patient cannot touch the nose, either it will go beyond nose or it will stop before nose. So it is called hypometria or hypermetria. So next is coming nose finger nose toast. For detect the for further modification or for minor abnormality, we will ask patient to touch first the patient's finger, then his own nose, then again the patient finger, and the examiner, not the examiner's finger, the patient nose, again the examiner's finger, and examiner will change the position of the finger frequently. So this is for the more finer accuracy of the finger nose test. Now coming to the heel shin test. This is for the accuracy of movement of the lower limb. First we put your heel like this and we'll proceed along the shin bone. If there is cerebellar disorder, is a zigzag fashion. It will not go along the shin bone. It will be like a zigzag fashion. And as your feet proceed to the angle, this tremor will increase. So this is called the heel test. This is equivalent to the finger nose test of upper limb. Is the toe finger test, finer accuracy. You put a hammer there, you ask the patient to touch the tip of the finger. It is like the finger nose test or finger nose finger test. This is for the lower limb finger nose finger test. Tandem gait. I told before, by tandem gait, minor abnormality of the vermis can be detected. Vermis is responsible for the gait abnormality. If there is a advanced case, there will be drunken gait, wide base gait, and there is a tendency to fall forward and backward. But tandem gait is a heel toe test. You like this. You put your heel in front of the toe. Walk like this. If there is a minor or early defect of the vermis, the tandem gait will be affected. You cannot walk on a toe heel manner. You cannot walk. This is called the tandem gait. Now is coming to the Romberg test. Romberg test basically, I will come later on. There is a sensory versus cerebellar ataxia. Pendular jack. You sit on a bed, knee outside the corner of the bed and strike your patella. You do on yourself. Normally swinging will be up to 4 times. But if there is a more than 4 times swinging and after that knee or the lower limb is coming to a halt, that is called pendular jerk. That means the swinging is more than the 4 times. Normal swinging is up to maximum 4, usually 3. Then this movement will stop. But pendular reflex basically due to the hypotonicity and lack of checking reflex of the lower limb. Pass pointing, very important. Patient and examiners both outstretch arm and touch each other index finger. There is no finger. The patient raise his arm and return back to the original position to touch finger. That means this is the examiner's finger. This is patient finger. I ask to touch finger. Okay. Again, I done like this. Again, come back. And examiner also raises finger. Patient also raises finger. So this procedure can be repeated in several times in different plane in both eye open and eye closed. And in cerebellar disease, arm will deviate outward to the side of lesion. That means I ask, you touch the finger. Normally I touch the finger. But cerebellar disease, it will go outward. It cannot touch, it will go outward. But in vestibular lesion, if there is a unilateral vestibular lesion, this pass pointing, pass means I cannot point, I am going away. That is called pass pointing. Will be present in both arms and pass pointing will be towards the lesion. But in cerebellar lesion, suppose I have a right-sided lesion, pass pointing in right arm will be present, but left arm will be non-verbal. But if there is a right-sided vestibular lesion, pass pointing will be present in both arms and both in the right side. This is a way I can differentiate between the vestibular lesion versus the cerebellar lesion. So now we are coming very briefly in 10 minutes, the approach to the cerebellar disorder. The cerebellar disorder basically in divided into three defined categories. One is the disorder of the equilibrium due to the disease of the flocculonodular lobe. So here we will get the different type of nystagmus. To recapitulate again, there is a gauge evoke nystagmus, then the rebound nystagmus, then the periodic alternative nystagmus, then the macrosquare wave, the ocular flutter, ocular opisthochronous. So these are the nystagmus and oculomotor abnormality we will get as a disorder of the equilibrium. Then the midline cerebellar disorder is a disorder from the vermis. So we will get the gait ataxia. So we can get the gait ataxia. Then the cerebellar hemisphere lesion. We will get the limb ataxia. That is the disorder of the coordination. And here to remember, in limb ataxia, arm will be affected more than the leg. So to come slightly in details about the midline syndrome, what is the etiology? It is the alcohol medulloblastoma. In alcohol, they affect the vermis. So vermis control the axial structure. So lesion in the midline structure, there will be defect in the walking, coordination of the head and tongue. In the mild disorder, the tandem gait will be affected. As the disease advances, there will be gross postural and locomotor imbalance. There will be tendency to fall forward and backward. Remember, in hemispheric lesion, there is a tendency to fall towards the side of lesion. That means laterally. But in vermis lesion, there is a tendency to fall forward or backward. Your gait will be wide waist, will be drunken posture, unable to stand upright, but no limb abnormality, no tremor, muscle tone will be normal, no dysarthria, and nystagmus may or may not be present. So this is this is for the midline syndrome, happens in particularly medulloblastoma and chronic or acute alcoholism. Next is coming to the hemispheric lesion. Hemispheric lesion is a more appendicular than the axial, and deficits are unilateral and manifestation is ipsilateral. Particularly the skill movement is more affected. In vermis lesion, it is the gait is more affected. Here is the skill movement is more affected. You want to write something, you want to play some instrument, you want to hold the tea bag. So this is the skill movement or will be more affected, and distal movement will be more affected than the proximal movement. I told several times the vermis is for the proximal muscle. Thigh movement is more affected than the coarse movement. Here in hemispheric lesion, we may get the intention tremor if the dentate nucleus is involved. Tendency to the fall towards the side of the lesion, broad-based walking, pass pointing is a feature of the hemispheric lesion. We cannot point the particular point, we pass. The dysarthria may occur due to the associated vermis lesion. Nystagmus may or may not be present. If there is the associated flocculonodular lobe, then we will get the nystagmus. Etiology is the astrocytoma, multiple sclerosis, medullary, lateral medullary syndrome. Diffuse cerebral, so midline syndrome, then hemispheric syndrome, then the diffuse cerebellar dysfunction. Diffuse cerebellar dysfunction we will get in the nystagmus, in gait abnormality, limb and truncal ataxia, and different disease, particularly the hereditary SCA, hereditary spinocerebellar ataxia, drug, particularly the phenytoin, toxin, cranioplastic syndrome. We will get the we will get this type of diffuse cerebellar also infection, different cerebellitis. Infection can cause the diffuse cerebellar dysfunction. Ataxia, we are coming very is the cardinal sign of the cerebellar disorder is the improper coordination of voluntary muscle movement affecting the rate, range, direction, force. And before stamping a patient ataxic, you should exclude the musculoskeletal disorder, muscular disorder, myoneural junction disorder, neuropathy, and myelopathy. When you have excluded these the 5 things, you can stamp it is a case of ataxia. Ataxia can be due to cerebellum, sensory, vestibular, optic, and frontal. Now, how will differentiate? Very important question. The cerebellar ataxia, there will be sensory loss, particularly joint and vibration position sense loss, and there will be steepage gait and reflex will be lost. But in the cerebellar ataxia, we will get the reeling gait, we will get the nystagmus, we will get the dysdiadochokinesia, dysmetria, hypotonia, pendular jerk. and the Rombach sign can differentiate between these two. Next is coming the vestibular ataxia versus cerebellar ataxia. Nystagmus can differentiate between two. In nystagmus in vestibular ataxia will be unidirectional and slow dip towards the peritic side, and very important, it is suppressed by the fixation. But in cerebellar ataxia, it is bidirectional, gauge epoch, remount, and first component is toward the site of lesion. In vestibular, first component away from the site of the lesion and not suppressed by the fixation. In vestibular ataxia, we will get associated vertigo and speech not involved. But in case of cerebellar ataxia, we will not get vertigo, but is dysarthria, hypotonia, gait abnormality may be present. But in vestibular ataxia, gait abnormality is less present. So now we get the frontal lobe ataxia. So in case of cerebellar ataxia, what we get? Decreased tone, hypodysreflexia. But in frontal lobe ataxia, we will get the ipsilateral cerebellar dysfunction, but tone will be increased and there will be hyperdysplexia because it is basically the cortical lobe is involved. So we have differentiate. First, we will rule out musculoskeletal disorder, myopathy, myoneural junction, neuropathy, myelopathy, which stamp is the ataxia. So we have a DD, vestibular ataxia, cerebellar ataxia, then the frontal ataxia, sensory ataxia. We will differentiate with the clinical background. Non-motor manifestation I described. So now the different cerebellar disorders. Now we are coming to the practical things. After completion of the aspect, clinical examination and theoretical aspect, it can be divided as a acute, subacute or chronic. Chronic may be static and progressive. Distribution can be ipsilateral, bilateral. It can be vermis or paravermis. It can be hemispheric. It can be pancerebellar, or it can be episodic, static, or progressive. So we have divided according to the onset, according to the distribution, according to the course. Acute lesion examples are the vascular, primary demyelination, post-infectious, viral infection, and different alcohol or warnings encephalopathy. Then we are coming to the subacute lesion. Subacute lesion can be unilateral progressive, bilateral progressive. Unilateral progressive may be mass lesion, demyelinating lesion, and infection like CIB or CID. And bilateral progressive, it can be due to different vitamin deficiency, alcohol, paraneoplastic, and hypothyroidism. Chronic lesion can be static, can be progressive. Among the static, it will be alcoholic cerebellar degeneration, Dandy-Walker syndrome, Arnold-Chiari malformation. And progressive, it can be autosomal recessive, Friedreich's ataxia, ataxia telangiectasia, or autosomal dominant spinocerebellar ataxia, or neurodegenerative condition like MSA, multisystem atrophy. Here we will get the features of the cerebellar dysfunction. Just one point to add in Friedreich's ataxia, this genetical disorder today we will not discuss, but one point very important in case of Friedreich's ataxia, if you get the cerebellar dysfunction with absent and ankle jerk and pre-adolescent onset, you think patient may have Friedreich's ataxia. So progressive gait ataxia, limb muscle weakness, absent jerk, extensor plantar response, other cerebellar dysfunction like dysarthria, and along with the posterior column decreased sensation, cardiac abnormality, all give clue of having the Friedreich's ataxia. But remember this point, along with the cerebellar dysfunction, if you get the knee jerk, ankle jerk absent and pre-adolescent, at least you search for the other finding and may get the Friedreich's ataxia. Episodic, very important. What are the etiology? It can be episodic ataxic syndrome, basilar migraine, recurrent toxin exposure, heart-nerve disease, and organic aciduria. These are the example of the episodic or recurrent ataxia. So based on the disease, we are summarizing by 2 slides, whole thing. So it can be medial, that means the lesion of the flocculonodular lobe. Here the symptom will be nystagmus, oculomotor disturbance, and gait ataxia. Medial means there is a involvement of the flocculonodular lobe and the vermis. Example is the medulloblastoma. Intermediate basically is the paravermis region. There will be gait ataxia and dysarthria. Example is the alcoholic degeneration. Lateral means there is a hemispheric involvement. So there will be limb ataxia. It is basically happens in the stroke and neoplastic lesion. Pancerebral, all of the above in the paraneoplastic or viral infection. So again, if we summarize the vermis, this can be rostral or caudal. Rostral vermis means is the anterior lobe. Remember the anatomy. There will be gait ataxia and impaired limb heel to shin sign. Infrequent hypotonia nystagmus dysarthria will be less common. In case of caudal vermis, that means more a flocculoneural lobe is involved. So there will be nystagmus, steepage gait, axial disequilibrium. Hemispheric lesion, there will be ipsilateral appendicular incoordination manifested by dysdiadochokinesia, dysmetria, and pancerebellar syndrome. So, lastly, it is a stroke syndrome of the cerebellum. Cerebellum is supplied from the basilar artery by three arteries: superior cerebellar artery, anterior inferior cerebellar artery, and posterior inferior cerebellar artery. These are three arteries supply the cerebellum. So, different cerebellar stroke syndrome. Not going details, we can get the slide. It is a superior cerebellar artery. There will be Horner syndrome because all these arteries supply the cerebellum along with the brainstem. So there will be mixture of the symptom of the along with the brainstem and cerebellum. So there will be anterior inferior cerebellar artery. There will be more involvement of the pontine symptom along with the cerebellar syndrome. So there will be deafness, deviation of the angle of the mouth. There is the seventh nerve involvement, dizziness, diplopia due to involvement of the sixth nerve and third, fourth, fifth, because it is the anterior inferior cerebellar artery. Whereas when there will be affection of the posterior inferior cerebral artery, there will be along with cerebellar syndrome, we'll get a more features of the lateral medullary. We can get the Horner syndrome. We can get the loss of sensation in the face because of the involvement of the trigeminal, and also dysphagia because of the involvement of the 9th and 10th cranial nerve. So according to the distribution of the artery, we'll get the mixture of the symptom along with cerebellum. We'll get other brainstem involvement. So this is called cerebellar stroke syndrome. So after this, now is the question, and another 10 minutes is there for the question answer section. So now I have put the self-assessment question. I will give question to Professor N.P. Singh. All student is asked. I have not given answer here. You read the PPT again. Whatever you have learned, again you read and you answer this question and send answer to Dr. N.P. Singh. I will send answer only to Dr. N.P. Singh and he will send to you. There you can do the self-assessment. This is one question, second question, third, fourth, fifth, sixth, seventh, eighth. This is the eighth question. One question probably I skipped, and that as there is 2 minutes I can discuss.
Jyotirmoy,
Yes, yes.
I have a request. If you can just read these questions for them, they will put the answer on the chat box, and then we can tell them whether they're right or not, rather than emailing it. We have some 10 minutes, so I think we can do this exercise.
Okay.
So if you want, I can read them for you.
Yes. So during question answer, I see I will answer and they will self-assessment.
Yeah.
70 years old man with history of hypertension went to work and a sudden onset nausea, vomiting. He was taken to ER, where his examination was notable for the slurring of the speech, dysmetria on finger to nose testing on the left side. His gait was normal. Where is the lesion? Is it a vermis lesion? It is a right cerebellar lesion. It is a left cerebellar lesion. It is a vestigial nucleus lesion. It is a vestibular nucleus lesion. What is the answer?
They put
now or later on?
I think we can answer them because it will benefit. The options given are C, A. I think they're all confused. So please read the two clues which you have. The patient has nausea, vomiting. The patient has a slurred speech, and left-sided finger nose test is disturbed, and there is a gait is normal. So people have said C. They are almost unanimity is C, that is left cerebellar hemisphere is involved.
Yes, very good. So now I am coming to the next question. 45 years old man was admitted to the hospital with cerebellar hemorrhage. Patient exhibited an unsteady drunken gait, and the physician noted there is swing movement while entering to the examination room. Which region of the cerebellum is most likely to be affected by hemorrhage? It is the anterior lobe, posterior lobe, interposed nuclei, dentate nucleus, flocculonodular lobe. Which part is affected?
Patient has a drunken gait
Drunken
and
gait.
he swayed while entering the exam. So,
Which region of is affected? See, it can be interposed by exclude. Flocculonodular lobe, it cannot be. It is for the equilibrium of the eye.
yeah.
Dentate nucleus can be it can be dentate nucleus for the it send fiber to the red nucleus and thalamus and cortex. So dentate nucleus involvement causes the tremor. I told you. Interposed nucleus not. Then hemisphere of the anterior lobe and posterior lobe. Anterior lobe contain the vermis. Vermis is more in the anterior lobe.
And
So,
that is what the
as there is a drunken gait, gait is basically by the vermis. So A is the answer.
So the first answer is right. I think this day some students did say.
Risdagh or kinesia refer to which of the following?
This is easier. I think you should be able to answer trainees.
Very easy. Very easy. It is E. Inability to perform rapid alternative movement with the hands.
Yeah.
Next we have come to the next
E.
question.
Started with.
Concerning the circuit between the Mosey fiber, climbing fibers, and cells of the cerebellar cortex, which of the following parts pair both provide the excited? This part I have not discussed.
Yes.
This part I have not discussed. Okay, so I am skipping this. But I can say something. So very interesting. The Mosey and climbing fiber, basically the olivary nucleus, the fibers entered to the cerebellum as a Mosey fiber, as a climbing fiber. But other fiber, whether sinocerebellar tract, uniocerebellar, or enter as a Mosey fiber. Cerebral cortex has a 3 layer: outer layer, then the Purkinje layer, then the granular layer. All the Mosey fiber and granular fiber, they come to the granular layer. Okay, from granular layer and the Purkinje fiber, they send the dendrite to the outer layer. Better at the end, I will come to the previous I skipped. I show it. It's very interesting. Your 70 years old patient display ataxia when asked to walk across the examination room. You ask him to stand still with eye closed and note marked swing back and forth. When he opens his eye, the swing persists. Vibrations is normal in all 4 limbs. Given the clinical picture in this case, such ataxia is likely to damage of which structure? That means this is a Romberg test. I have not described.
Romberg is positive.
Which part is involved? In case of which part is involved? In case of sensory ataxia, when your eyes is open, the swinging will decrease. But when eye will be closed, swinging will increase. Okay. But in cerebellar disorder, whether your eye is open or closed, both way, there will be swinging because cerebellum receive input from one from eye, one from posterior column. So this is the final relay center. So if there is a defect in the posterior column, your one input is okay. So swinging will be less when eyes is open. But in case of cerebellar disorder, it is the final realization. Whether your eyes is open or closed, swinging will increase. So here with eyes closed, swinging increases. So this is the dorsal column lesion. This is the Romberg test. Next, from the actions of the dentate nucleus terminate in what thalamic nucleus and travel through what peduncle? I told many times. It dentate nucleus pass through the superior cerebellar peduncle. Okay, to the red nucleus and thalamus. So answer is superior cerebellar peduncle. As a researcher studying the circuit of the cerebellum, which of the following nuclei known to be major output neuron
Cerebellar cortex.
of the cerebellar cortex output neuron. What is the output neuron?
Dentate.
That part I have not discussed. I go back to the original slide. So then it will be easy. Which of the following ascending pathway enters the cerebellum through the peduncle marked in the picture? Picture not very clear. Which of the following this picture not very clear? You skip
Yeah.
this picture. Thank you.
So I think, dear trainees, I think you will all agree that sir has put in a lot of efforts, and in last 40-45 minutes, he has been able to not only give you the anatomy and physiology of cerebellar cortex, but also he has practically touched upon all the disorders which is in which this patient can present with cerebellar disorders, whether it is acute, subacute, chronic, whether it
Just
is
1 minute.
central.
This picture I got. The two question I skipped. The whatever the afferent fibers, spinocerebellar, cuneocerebellar, all come to the granular layer. From granular layer, action go to the this molecular layer. And Purkinje cells, they have a dendrite here. So this is like this. Input come to the granular layer. Granular layer it go to the molecular layer. Molecular layer it is picked up by the Purkinje cell. Then the Purkinje cell send action to the deeper nucleus. That is the vestigial nucleus, dentate nucleus. From dentate nucleus, it is going to the again brainstem to the red nucleus and corticospinal tract to the motor cortex. So it comes like this, then Purkinje fiber, then to the deeper nuclei to superior cerebellar peduncle to the red nucleus, thalamus, cortex. So this is the pathway of input and output. Thank you. So now is the time of the question.
The first question is, of course, confusion between sensory ataxia and cerebral ataxia. Sir has very clearly pointed out, Dr. Tyagi, that sensory ataxia will occur when Romberg sign will be positive. When the patient closes his eyes, he will sway. And the moment he opens, he will be able to use his eye sense. And that is how the swaying will not be there, right? While in cerebellar, irrespective of whether his eyes is closed or open, the ataxia will be there. Dr. Jyotirmoy, one question is cerebellar output is dentate or Purkinje? Can you just
stop sharing? Yes, I have stopped sharing. Little better. Sir, what is the question?
is the dentate is the cerebellar output dentate or Purkinje?
Yes, it is cerebellar output basically from the Purkinje. From the Purkinje, it can go to the dentate nucleus. If the output go to the cerebral cortex, it can go to the vestigial nucleus. If you go to the vestibules, so by different nucleus, it is going to the different area of the brain. So output is from the Purkinje.
So I just have a question, Dr. Jyotirmoy. In your experience, what are the common syndromes, cerebellar syndromes, which can present apart from vascular, which are common in elderly? I think post-pyrexial or sometimes drug-induced cerebellars can also. Have you? I've had a case of severe hypothyroidism presenting as cerebellar syndrome. So these are some of the rare presentations. So in your experience, what are the common cerebellar situations where you can deal with? Of course, you did talk about Friedreich's ataxia. I think it used to be one of the.
Not common. So basically, we divide in the three category: acute, subacute, and chronic. In three category. In acute, we can see in case of different viral infection, in case of vascular lesion, and even after taking a lot of alcohol. So subacute, we can see after different vitamin deficiency, hypothyroidism, paraneoplastic, and also for the malignancy, medulloblastoma, and others. And chronic, we will see basically in different degenerative conditions such as SCA, we can see in Friedreich's ataxia, we can see in the multisystem atrophy.
Right. Thank you. And then this question is severe B12 deficiency can also cause cerebellar symptoms?
Yes. I have shown it in the subacute. If you remember when I categorize acute, subacute, and chronic, in subacute section, I showed two vitamin can cause the symptom. One is B1, one is the B12.
B12 symptoms, right. So I think they must have understood a lot. You did almost cover almost everything related to cerebellum, and there there are not many questions coming up. So Friedreich's ataxia is very interesting. I think where you have both spinothalamic involved, uh, long lead involvement, as well as the long track involvement, as well as the cerebellar involvement. And here, patients generally succumb to cardiomyopathy, or I remember one family who had severe diabetes, diabetes mellitus, which can, especially ketoacidosis, may also be accompanying with them. So these are some of the rare genetic disorders. I think the students should be able to basically differentiate, as you said, the etiology. Pica syndrome is also very commonly seen in the exams, and there they have again a combination of low cranial nerve involvement with cerebellar involvement. And uh, what is the general treatment for ataxia? There, someone is asking, sir.
Yes, this is depends on the etiology, because ataxia ataxia depends on the etiology you treat. It can be, suppose, hypothyroidism. I also seen one case severe hypothyroidism present with the ataxia. So then you treatment of the hypothyroidism. It can be to the vitamin deficiency, or it can be to neurodegenerative disorder. In case of neurodegenerative disorder, you cannot do much. But there is some cases of the reversible ataxia, some are irreversible ataxia. So your duty is to differentiate what are the, is there any reversible cause for the ataxia. So
Absolutely.
treatment of ataxia depends on the etiology.
Right. I think we'll close here, Dr. Jyotirmoy. We've almost
Sending my
exceeded the
PPT to
time,
you, you can
and
upload and give to the students.
thank you very much, Dr. Jyotirmoy. I think you must have worked hard to actually make these slides. I understand that how it is difficult to prepare these slides, but I'm very sure the students will get immensely benefited. And now that National Board has also made a provision of providing them with some recordings, so that will help them a lot. And on behalf of National Board, I thank you again. And I'm very sure we'll invite you again after some time to talk to the students on a different topic. And over to you, Navneet, for conclusion.
I send my PPT to you in your
Right,
WhatsApp.
sir.
Okay.
Thank you.
Thank you. Thank you.
Thank you. Thank you very much, Dr. Jyotirmoy Paul, for the presentation, and thank you very much, Dr. Narendra Pal Singh, for joining. And thank you, trainees and faculty members, for joining.
Thank you. Thank you.